Heart attacks and strokes kill more seniors than all cancers combined, claiming over 800 American lives annually. While most people focus on diet and exercise for cardiovascular health, a hidden danger lurks in medicine cabinets across the country: prescription medications that dramatically increase heart attack and stroke risk in adults over 65 years old. The paradox is devastating. Seniors take medications believing they're protecting their health. Yet certain drugs prescribed routinely to elderly patients actually trigger the cardiovascular events they're meant to prevent. Understanding how medications trigger cardiovascular catastrophes requires examining several mechanisms. Some drugs increase blood pressure acutely, rupturing vulnerable atherosclerotic plaques. Others cause sodium and fluid retention, overloading the cardiovascular system and precipitating acute heart failure. Some medications increase heart rate and contractility dramatically, raising myocardial oxygen demand beyond what diseased coronary arteries can supply. Additionally, certain drugs promote blood clot formation through platelet activation, increased coagulation factor production, or endothelial dysfunction. Some cause coronary artery spasm, suddenly constricting arteries even without significant atherosclerosis. Others alter electrolyte balance, creating conditions for fatal arrhythmias. The vulnerability of seniors to medication-induced cardiovascular events stems from age-related physiological changes. Aging kidneys metabolize and excrete drugs more slowly, causing accumulation to toxic levels. Aging livers process medications less efficiently, prolonging drug half-lives. Reduced cardiac reserve means elderly hearts cannot compensate for additional stresses. Pre-existing coronary disease makes seniors particularly vulnerable. Additionally, polypharmacy, taking multiple medications simultaneously, creates unpredictable drug interactions, triggering cardiovascular events. The average senior over 65 takes 4 to 6 prescription medications daily, with 25% taking 10 or more. Each additional drug increases interaction risk exponentially. Research published in JAMA Cardiology documented that medication-induced cardiovascular events account for 15 to 25% of heart attacks and strokes in seniors over 70. Many are preventable through careful medication selection, appropriate dosing, and regular medication reviews. The tragedy is that prescribers often don't consider cardiovascular risks when adding medications to elderly patients' regimens. Each specialist focuses on their organ system, missing the big picture of total medication burden and cumulative cardiovascular risk. The 5 pills discussed in this video represent those with the strongest evidence for triggering heart attacks and strokes in seniors over 65. Each medication class is explained with mechanisms of cardiovascular harm, statistics on risk increases, and safer alternatives when available. Click subscribe now, leave a like for the algorithm, share with seniors taking multiple medications. Comment which pill on this list surprises you most. Now let's examine 5 pills that raise heart attack and stroke risk in seniors. Pill number 5, proton pump inhibitors causing magnesium depletion and fatal arrhythmias. Proton pump inhibitors PPIs, including omeprazole, pantoprazole, and esomeprazole, are among the most prescribed medications worldwide, with 68% of adults over 60 taking them daily for heartburn, reflux, or stomach protection. The pharmaceutical industry promotes these medications as harmless stomach protectors, especially when taking other drugs. But the reality is that PPI destroy cardiovascular health through mechanisms so subtle that death seems natural when it finally occurs. PPI work by blocking gastric acid production in the stomach, but stomach acid doesn't just aid digestion. It's essential for absorbing magnesium, vitamin B12, iron, calcium, and vitamin D from food. When acid production is blocked for months or years, massive nutritional deficiencies develop that silently destroy cardiovascular function. Magnesium deficiency is especially deadly because this mineral is essential for over 300 enzymatic reactions in the body, including heart muscle contraction and relaxation. Elderly people already have naturally lower magnesium levels. When PPI are added, severe depletion occurs that can cause sudden death by ventricular or arrhythmia, chaotic heart rhythm preventing effective pumping. Independent studies show that PPI use for more than 1 year reduces magnesium levels by up to 60%. Research published in the Archives of Internal Medicine found that PPI users had a 90% increased risk of dangerous heart rhythm abnormalities compared to non-users. The vitamin B12 deficiency caused by PPI is equally devastating for the heart. Vitamin B12 is crucial for energy production in heart cells and maintenance of the heart's electrical system. When B12 absorption is blocked, the heart functions with chronic energy deficiency that eventually leads to heart failure. B12 deficiency also causes elevation of homocysteine, a toxic amino acid that directly damages coronary arteries and dramatically increases risk of blood clots. People using PPI for more than 2 years have homocysteine levels 40% higher than normal, creating chronic arterial inflammation. PPI also interfere with metabolism of clopidogrel, an antiplatelet drug many seniors take to prevent clots, making it completely ineffective. This deadly drug interaction has been known for over a decade, but continues to be ignored. Research published in PLOS found that PPI use increased heart attack risk by 16 to 21%, with risk rising the longer PPI were used. Another study in Circulation found a 70% increased risk of stroke in long-term PPI users. What you must do if taking PPI is work with your physician to gradually reduce and discontinue them. Never stop abruptly because rebound acid hypersecretion can occur. Reduce dose by 50% for 2 weeks, then alternate days for another 2 weeks before stopping. Simultaneously implement natural protocols including eliminating inflammatory foods like gluten, dairy, and processed foods, adding digestive enzymes, especially beta-IN HCl, supplementing with chelated magnesium 400 mgs daily, vitamin B12 methylcobalamin 1,000 micrograms sublingually, and vitamin D3 with K2, using high-potency probiotics, and for acute symptoms, occasional baking soda or chamomile tea. Pill number 4, beta blockers causing progressive heart failure and diabetes. Beta blockers, including metoprolol, atenolol, and propranolol, are prescribed to 45% of adults over 60 for blood pressure control and heart rhythm management. Doctors prescribe them liberally, promising cardiovascular protection when actually they create time bombs. These drugs are promoted as essential for controlling blood pressure and preventing heart attacks. But the shocking truth is that beta blockers cause progressive heart failure, diabetes, severe depression, and can kill during sleep through extreme bradycardia, dangerously slow heart rate. Beta blockers work by blocking beta-adrenergic receptors in the heart, preventing it from responding properly to adrenaline and noradrenaline signals essential for maintaining heart function during Stress or emergencies. When beta blockers are taken chronically, the heart's natural ability to speed up when necessary during exercise, stress, or medical emergencies is shut down. For elderly people whose hearts already function with reduced capacity, this artificial suppression can be fatal. During sleep, when the parasympathetic nervous system naturally reduces heart rate, beta blockers can cause extreme bradycardia, resulting in sudden cardiac arrest. Episodes of heart pausing during the night are signs that beta blockers are causing dangerous interruptions in heartbeat. Research published in the European Heart Journal found that beta blocker use in elderly patients without heart failure or recent heart attack increased mortality by 14% compared to non-use. The drugs provided no benefit but caused substantial harm. Beta blockers also cause insulin resistance and type 2 diabetes in alarming percentages. They block signals that normally stimulate insulin release and reduce tissue sensitivity to insulin, forcing the pancreas to work on overload. Over time, pancreatic exhaustion leads to frank diabetes, exponentially multiplying cardiovascular disease risk. Studies show beta blocker use increases diabetes risk by 28% in adults over 60. Beta blockers also mask symptoms of hypoglycemia, preventing diabetics from noticing when blood sugar levels are dangerously low, resulting in hypoglycemic comas that can be fatal, especially during sleep. Additionally, beta blockers cause severe depression and cognitive decline by crossing the blood-brain barrier and blocking beta receptors essential for neurotransmitter production, including serotonin and dopamine. The result is drug-induced chemical depression. Reduction in cerebral blood flow caused by beta blockers contributes to progressive cognitive decline, with many developing symptoms mimicking early dementia. What you must do if taking beta blockers is never stop abruptly because severe rebound hypertension, dangerous tachycardia, and heart attacks can occur. Work with a physician to reduce dose gradually over 4 to 6 weeks while implementing natural cardiovascular support. Immediately supplement with coenzyme Q10 and chelated magnesium to support natural heart function. Add taurine, which strengthens heart muscle without suppressing responsiveness. Implement deep breathing exercises and meditation that naturally activate the parasympathetic system. Eliminate refined salt and processed foods, increasing potassium through fresh vegetables. Use stress reduction techniques like gentle yoga, acupuncture, and massage. Investigate root causes of hypertension, including insulin resistance, magnesium deficiencies, heavy metal toxicity, sleep apnea, and chronic stress. Pill number 3, nonsteroidal anti-inflammatory drugs increasing heart attack risk by 50%. NSAIDs, including ibuprofen, naproxen, diclofenac, meloxicam, and celecoxib, are among the most commonly used medications worldwide, available both over-the-counter and by prescription. 84% of adults over 60 take NSAIDs regularly for pain and inflammation. For seniors over 65, NSAIDs dramatically increase cardiovascular event risk through multiple mechanisms. These drugs inhibit cyclooxygenase enzymes that produce prostaglandins involved in inflammation, but prostaglandins also regulate critical cardiovascular functions. ZOX2 inhibition reduces prostacyclin production by vascular endothelium. Prostacyclin normally prevents platelet aggregation and causes vasodilation. Reducing prostacyclin shifts balance toward prothrombotic and vasoconstrictive states, increasing heart attack and stroke risk. Additionally, NSAIDs cause sodium and fluid retention by affecting kidney prostaglandin synthesis. This increases blood volume and blood pressure, worsening heart failure and hypertension, both major cardiovascular risk factors. NSAIDs also cause direct endothelial dysfunction, impairing blood vessel lining's ability to regulate blood flow and prevent clot formation. This accelerates atherosclerosis progression and destabilizes existing plaques. Research published in the European Heart Journal examined over 10 million NSAID users and found that any NSAID use, even for short durations, increased heart attack risk by 20 to 50%, depending on the specific drug and dose. Diclofenac showed highest cardiovascular risk, increasing heart attack risk by 50% and cardiovascular death risk by 70%. Ibuprofen at high doses increased risk by 48%. Even naproxen, considered the safest NSAID, increased risk by 20 to 30%. The risk begins within the first week of use and remains elevated throughout treatment. There is no safe duration of NSAID use. Cardiovascular risk exists from the first dose. A meta-analysis in the Lance, it found that NSAIDs increased major vascular events, including heart attack, stroke, and cardiovascular death, by approximately 1/3. For every 1,000 people treated with NSAIDs for 1 year, there were 3 additional major vascular events. Populations at highest risk include those with prior heart attack or stroke, heart failure, hypertension, diabetes, chronic kidney disease, and those taking aspirin for cardiovascular protection. NSAIDs interfere with aspirin's antiplatelet effects. What you must do is avoid NSAIDs if you have cardiovascular disease or risk factors. Use acetaminophen as first-line pain reliever instead. While acetaminophen doesn't reduce inflammation, it provides effective pain relief without cardiovascular risks at recommended doses under 3,000 mg daily. For inflammatory conditions requiring anti-inflammatory treatment, discuss alternatives including low-dose prednisone, topical NSAIDs like diclofenac gel providing localized relief with minimal systemic absorption or disease, modifying medications for specific conditions. Natural alternatives include high-absorption curcumin 500 mg twice daily with piperine, which is more effective than ibuprofen at reducing inflammation without cardiovascular side effects. Add high-quality wild fish oil, 2 to 3 grams daily of EPA and DHA, a powerful natural anti-inflammatory. Physical therapies like ice, heat, massage, acupuncture, and low-impact exercises treat pain's root cause instead of masking symptoms with drugs. Pill number 2, Anticoagulants causing fatal hemorrhages more often than preventing clots. Anticoagulants, including warfarin, rivaroxaban, apixaban, and dabigatran, are prescribed to prevent blood clots in patients with atrial fibrillation or history of clots. 91% of doctors prescribe these automatically for seniors, believing they're saving lives when actually they're creating hemorrhage risks. The pharmaceutical industry has convinced doctors and patients these drugs are essential to prevent strokes and embolisms. But the terrifying truth is that anticoagulants kill more elderly people through fatal hemorrhages than they save through clot prevention. Anticoagulants work by blocking essential factors in the coagulation cascade, preventing blood from forming clots, not just dangerous clots, but necessary clots after any injury. For elderly people whose blood vessels are already fragile and whose livers process medication slowly, this interference can turn minor trauma into catastrophic hemorrhage. When anticoagulants are taken chronically after age 60, patients constantly live on the razor's edge between clot prevention and death by bleeding. What makes this more dangerous is that newer anticoagulants like rivaroxaban and apixaban have no effective antidote. If bleeding starts, there's no way to quickly reverse effects. Research published in JAMA found that major bleeding rates with newer anticoagulants ranged from 2 to 4% annually, seemingly small until you realize this represents tens of thousands of people suffering life-threatening bleeds yearly. The situation becomes more deadly considering elderly patients on anticoagulants often develop silent gastrointestinal bleeding lasting weeks or months before becoming fatal. The stomach and intestinal lining in elderly people is already thinner and more vulnerable. When potent anticoagulants are added, any minor irritation can cause bleeding that never stops properly. Thousands die annually from severe anemia caused by chronic gastrointestinal bleeding that went unnoticed until too late. Bleeding can be so gradual that increasing fatigue and weakness are attributed to normal aging, while patients are losing blood internally every day. Anticoagulants interact dangerously with common medications like aspirin and NSAIDs, exponentially multiplying fatal hemorrhage risk. Yet many doctors prescribe these deadly combinations without considering consequences. Anticoagulants also cause paradoxical arterial calcification. Warfarin blocks vitamin K, essential not only for coagulation, but also for keeping calcium in bones and out of arteries. Chronic vitamin K blockade forces calcium to deposit in arterial walls, creating stiff arteries more prone to rupture. What you must do if taking anticoagulants is understand that withdrawal requires strict medical supervision. However, natural alternatives can offer cardiovascular protection without hemorrhage risks. Implement natural anti-inflammatory protocols with high absorption curcumin, wild fish oil, and aged garlic extract, which naturally reduce platelet aggregation without completely blocking coagulation. Add nattokinase, a natural enzyme that dissolves clots safely and reversibly. Supplement with vitamin K2, if not on warfarin, to keep calcium in bones and out of arteries. Use chelated magnesium, which relaxes blood vessels and reduces excessive coagulation tendency. Eliminate pro-inflammatory and procoagulant foods like refined sugar, processed vegetable oils, and grain-fed animal meats. Practice low-impact exercises improving circulation without trauma risk. Pill number 1, statins destroying heart muscle while blocking life, saving cholesterol. Statins, including atorvastatin, simvastatin, and rosuvastatin, are the most prescribed drugs worldwide to lower cholesterol. 73% of elderly adults take statins daily, believing they're investing in longevity when actually they're destroying the very organ they're meant to protect. Statins are promoted as essential to prevent heart attacks and strokes. But what 99% of doctors don't know or refuse to admit is that statins literally destroy heart muscle, causing statin-induced myopathy that can progress to fatal rhabdomyolysis, massive muscle tissue destruction, releasing deadly toxins into the bloodstream. The mechanism involves blocking coenzyme Q10, essential for energy production in heart cells. Statins work by blocking HMG, a reductase enzyme in the liver to reduce cholesterol production. But this same enzyme produces coenzyme Q10, the fuel allowing heart cells to contract and pump blood efficiently. When statins are taken for months or years, the heart is literally deprived of energy needed to function, creating progressive heart failure that develops so slowly it's attributed to natural aging. People over 60 already have naturally reduced coenzymes, IMQ-10 levels. Adding statins creates cardiac energy deficiency that can be fatal. Independent studies show statins reduce coenzymes, IMQ-10 levels by up to 40% in just 30 days. Statins also block cholesterol production in the brain, where this substance is essential for neurological function and cell membrane integrity. Contrary to medical propaganda, cholesterol is not poison. It's a vital substance produced by the body to repair damaged arteries, produce essential hormones, and maintain brain function. When cholesterol production is artificially blocked, the body is forced to consume its own muscle tissue to obtain necessary components for vital functions, a process called protein catabolism that literally consumes heart muscle. Research published in the American Journal of Cardiovascular Drugs found that statins cause muscle problems in 10 to 25% of users, ranging from mild myalgia to life, threatening rhabdomyolysis. Statins also cause type 2 diabetes in alarming percentages, creating a vicious cycle where heart medicine causes diabetes, which damages the heart more severely. Studies show statins increase diabetes risk by 48% in post-menopausal women and even higher in men over 65. What you must do if taking statins is never stop abruptly without medical supervision, because withdrawal syndrome can cause severe arterial inflammation, triggering heart attacks. Work with a physician to gradually reduce dose while implementing proven natural cardiovascular protocols. Immediately supplement with high-quality coenzymes, IMQ-10 100 to 200 mg daily to protect against energy deficiency. Add chelated magnesium 400 mg daily to protect against muscle cramps and arrhythmias. Implement a diet rich in healthy fats like extra virgin olive oil, avocado, and wild fish, providing building blocks for proper cholesterol production. Question the narrative that high cholesterol is dangerous. Studies show elderly people with cholesterol 200 to 280 live longer and have better cognitive function than those with artificially low cholesterol. These 5 pills raise heart attack and stroke risk in seniors. Proton pump inhibitors causing magnesium depletion and arrhythmias. Beta blockers causing progressive heart failure and diabetes. NSAIDs increasing heart attack risk by 50%. Anticoagulants causing fatal hemorrhages. And statins destroying heart muscle while blocking life, saving cholesterol. The pattern connecting these pills is that benefits may not outweigh cardiovascular risks in elderly patients with pre-existing conditions. Careful risk-benefit assessment, safer alternatives when available, lowest effective doses, and vigilant monitoring can reduce medication-induced cardiovascular events. Which pill surprised you most? Comment below. Share with seniors taking multiple medications. Subscribe for more medication safety content. Thank you for watching this video about pills that raise heart attack and stroke risk in seniors. Review your medications with your physician to minimize cardiovascular risks.